Cortical removal can be challenging in the presence of a large and mobile capsular bag associated with severe zonular weakness with an increased risk of zonular and capsular complications. Let's see how we manage this case. This is a case of cataract surgery in highly myopic eye with a very large and mobile capsular bag. So after creating the main incision and injecting an intracameral mydriatic agent, the iris moves toward the wound, suggestive floppy iris behavior. Here, as we see, the entire capsular bag moves as we attempt to puncture the anterior capsule. The capsular axis is therefore initiated carefully with minimal pressure on the weakened zonules. The pale fundus reflex visible here is related to extensive chorioretinal atrophy. So after completing the capsular axis, hydrodissection is performed gently. Once again, the floppy iris tends to move toward the incision, so controlled fluidics are essential to maintain chamber stability and limit iris and capsular bag movement. The nucleus is then removed using the flip and chop technique. This is our preferred approach in these cases because it allows us to manipulate the nucleus within the deep anterior chamber rather than performing extensive manipulation inside the unstable and mobile capsular bag. We now reach cortical aspiration, which is usually the most difficult and time-consuming step in cases like this. As we see here, the capsular bag is very large and the peripheral cortex is located far from the center. In addition, the mobility of the bag makes it difficult to engage and remove the cortex safely. At this stage, we attempt to remove as much cortex as possible before inserting the capsular tension ring. This reduces the risk of trapping cortex fibers between the CTR and the capsular equator. Here, the chopper is used to gently retract the iris and facilitate the introduction of the irrigation aspiration probe. Here, the cortex is removed using slow, controlled tangential movements. Instead of pulling the cortical fibers directly toward the center, we aspirate them circumferentially, following the equator of the capsular bag. So, this tangential approach minimizes traction on the weakened zonules and limits further displacement of the bag. These highly myopic eyes are challenging because of their deep anterior chamber, large capsular bag, weak zonules, mobile posterior capsule, and increased sensitivity to fluidic fluctuations. The capsular tension ring is then inserted into the capsular bag. The CTR expands the capsular equator, redistributes tension around the bag, and improves its stability during the removal of the remaining cortex. Then the residual cortical fibers are again removed using slow and controlled tangential movements, followed by cautious capsular polishing. The posterior capsule remains mobile throughout this step. The aspiration part must therefore remain continuously visible. Aggressive aspiration and excessive capsular polishing should be avoided to reduce the risk of posterior capsule rupture. And once the capsular bag is sufficiently clean and stable, we proceed directly to intraocular lens implantation. A foldable single-piece acrylic intraocular lens is loaded in the injector, then implanted. Although the calculated power was -3 diopters, we selected -2 to target slight myopia. We show directly the end of the case. After implantation, iris prolapse occurred, so the iris was repositioned and intracameral pilocarpine was injected. The incisions were then hydrated, followed by an intracameral antibiotic and subconjunctival dexamethasone. Thank you for watching.